My name's Dr. Ian Jackson. I'm an interloper here. I'm a consultant anaesthetist by background. But why I'm here will become clear shortly. The presentations today, I have to state, I'll give this Boston Scientific require me to show this statement. I'm not going to read it out to you. I'm sure you've seen statements like it several times in the past. But the agenda today is for myself, as immediate past president of the International Association for Ambulatory Surgery, to set a degree of context about the importance of ambulatory surgery, day-case surgery, for health service economies. We are then having a talk about the clinical use of the GreenlightTM Laser System. At the moment, Mr. Gordon Muir hasn't quite arrived yet. So we have a plan B, where Professor Tubero from Italy has agreed to talk if he doesn't make it. So thank you very much for that. So, the context. Why is day surgery or ambulatory surgery important? What is the global context? So we'll have a look at that. I'll have a little bit about specific UK context, because I suspect there are a few UK people here, and just give you an oversight of that. Across the world, there has been a requirement for us to minimize costs. And I'm going to show you an interesting graph about that. And one of the ways that we are minimizing costs within the acute sector in the hospital sector is by maximizing the use of day surgery and maximizing short stay surgery with enhanced recovery. And this is the graph that really shows it and brings it home to what happened when the bankers led to our economic crisis across the globe. You can see the huge reduction in health service spending across OECD countries. It was a phenomenal difference that occurred, and we've all felt it. And this just shows you the relative position in funding between 2000 and 2011. So you can see the funding in the early stage before, in light blue, before the economic crash, and then in the dark blue, you can see the levels of funding that have happened since then. An interesting thing for us, obviously, in the UK is, though, that we're supposed to have had level health spending or a slight increase in health spending, the reality is, with health service inflation, we've all seen a major reduction in the amount of money we have for health services. The only countries that seem to have managed to maintain a degree of funding are places like Sweden, Chile, and Korea, and to a degree, North America. The UK context is quite interesting, and this one, I like this graph. My head of finance used it, and I took it from him. I pinched it from him, because it basically covers the time since I qualified to date. So I actually qualified in 1981. And so that first dip that you can see, 85 to 1990, was the Maggie Thatcher years, when we had a huge reduction in spending in the health service. We then saw a bit of an increase in funding from the Tories, and then we moved into a Labour government from early towards 2000, and there was a massive increase in funding to the health service over that period, the next decade. And of course, since the economic crash, we've seen a reduction in net spending against our gross domestic product in the NHS. And this has led to problems. I could add another A to this. This is from the Monitor website in this country. Monitor is the organization that looks after foundation trusts in this country. And if you are put under special measures by Monitor for reasons usually of finance or question mark over patient safety, they publish your name in the naughty bit of their website. I got fed up when I got to D in the alphabet. There are huge numbers of hospitals under special measures in the UK, and most of the cause is funding. So I'm just trying to give you an idea that actually the move to ambulatory surgery is a huge, huge importance in all health economies. And day surgery, I believe, is part of the solution. When I was president of the British Association of Day Surgery back in 1996, we produced the first BADS Directory of Procedures. It's now on its 4th edition. And we benchmarked over 180 procedures, working with specialty leaders in the field, trying to create what was expected lengths of stay for various procedures. And urology had its own page. And it's very UK-centric because the coding is OPCS coding, but allowed trusts to look at how they were performing against the potential best performance. And this is from the 4th edition, which had resection of prostate by laser added. It's very difficult. People are doing it in the UK to do TURP using diathermy successfully as a day case, but the numbers that you can put through is very limited. Whereas the evidence seems to be supporting, and hopefully we'll hear very shortly, the move towards resection of prostate by laser. And indeed, our expert panel reckoned that something like 75% of these patients could be managed on an ambulatory care basis. So that's the context we're working on. I'd like to now call on Professor Toubereau to do the next session part. Thank you very much indeed.